draw any real-world examples of successes that you've seen in your career?
Yeah, I think it's still early days, but the power of generative AI to first of all access large parts of the medical literature and do a better form of search. Because if you think about it, in the past we all used search in the medical literature, whether it was just the basic searches that are available on the internet, or sometimes some more specialized or informed searches. And they would basically provide us for page after page of papers, which we would then have to digest and read. But they might give us a little extract from the paper, which was sometimes useful, but we'd basically then have a massive reading list of 10, 20, 30 papers to go through, or articles. And then, of course, we'd have to filter out the ones that were trying to sell us something, and the ones that were credible, the ones that were not. And so it was, of course, much better than having to travel over to the library and go through volumes of musty material. It's much better than that, but still not at all as good as a digested version that is focused on exactly what we were looking for, and in fact even had a summary capability. Now that summary capability, as we've all experienced, is extremely powerful. Even if it's not completely accurate, it's still very, very useful, because some of the best Gen AI tools give pointers to the material. Some don't, by the way, too. So we need to be aware of that. Some don't give pointers. You don't know where it got it from. And if you ask it, it then gives you a paper which isn't the source of the material. They got it from somewhere else. Or they interpolate it between two papers or whatever. Or they made references up even, right? Which is the most annoying thing of all. But if you have a tool like Clinical Key AI, which gives you the references, and then you can just maybe go and read 3 or 4 papers to get an answer to a question, whether it's a research problem or a patient problem. And in that way, you have both the summary, which is the overview, which we all need, but it also gives you the raw material, the source material, which you can then go and look at it and read the confidence intervals and see if you believe the paper, etc. And you can also look at the dates and the citations of the paper to see, how it's been received, and is it truly credible. So when you have this much more capable digest of information that the Gen AI can provide you, as long as it's done well, then you're in a much more amplified position than we were even in 2 or 3 years ago, when we had to mostly rely on search.
Absolutely. And one of my friends who's also in technology, I was demoing it to him. He's not medical at all, and he said, "Well, so you guys are not black box. You're like a glass box. I can peer inside and look under the hood," and that's something that stuck to my head. Because it is exactly what clinicians don't like, is a black box. They don't just like the answers. They need to know where you got, what you got, and why you're saying it from. And that's really vital. And speaking of adoption, what do you think are the main barriers of adopting new technologies like generative AI? And how can organizations, especially from a CTO, from a technology lead's perspective, how do you overcome these? In my world, it's usually, speaking for the clan, it's the change management, to sit down and win hearts and minds.
Yeah, so maybe I answer that for all of AI, because we're not just in a Gen AI world. We're in a world where AI is doing a lot of things for us. Like, for example, machine learning. Even though that's been around for a bit longer, actually quite a lot longer, the biggest challenges are actually being able to get models and get AI solutions that are reliable, based on really the right data, which means may mean being tuned for your region, your population, your genotype, your phenotype, etc. And of course, along with that comes the avoidance of bias. We don't want to have a solution which is, say, tuned on a Western population, and then we try to apply it in an Asian population or an African population where there might not have been sufficient sufficient training. And that bias could even occur within countries, since we have different ethnicities, we have different socioeconomic statuses, which are a huge source of differentiation in terms of medical outcomes. So having that data and having the tuning of the models is very, very critical for that. But then in terms of the more advanced tools, it's really safety and credibility. And there's quite a few papers coming out now in the literature on the use of AI and how clinicians interact with AI and how they use it and when they believe it and when they don't believe it. And there's some indication from recent publications that actually clinicians may have to be trained or maybe change their ways a little bit to make the maximum use out of AI. And this is, like, for example, even in the context of radiology, where there have been huge advances, I would say AI is further along in radiology and medical imaging than in any field. But clinicians still have to learn how to use AI in an appropriate way. They know they need to know kind of when to trust it, when to believe it, when to use it for shortcuts, when not to use it for shortcuts. They need to, the leaders need to figure out how it affects workflow, how much validation, how much checking do we do, how much auditing is it so-called, the so-called process do we do, how do we use it? So we need to fit it into workflows. And then we've already talked about the ideas of reaching into the literature and so on. The issues are still safety and testing, getting better and better all the time. But some clinicians will use it and make good use of it and filter it and be appropriately skeptical of it. There is a chance that some will use it in too cavalier a fashion. Will use it and simply copy from it or believe it too readily. And all of these behaviors are being documented in current research. We have a lot to learn, and I think we need to take into account in our training of students and residents, etc. We need to actually train them in how to use AI, and we have to adapt our workflows and our processes so that AI is used appropriately, not underused or overused, like any other tool.
And I think that's really relevant, and that validates sort of a report that Elsevier does. It's a Clinician of the Future. And we recently did one specifically on AI, questions leading to AI. And what the outcome said was that AI is not going to replace your clinician, your physician or your nurse, but you would be expected as a clinician to be able to use AI in your clinical workflows better. And that's exactly the summary of it in a sense. The expectation and the sense of urgency is that you need to use AI ethically, responsibly in workflows, otherwise your work is unsustainable. So that's a very important point, and thanks. Just going back to the healthcare system, or let's zoom out a bit to a level of a country. What do you think is the infrastructure that a healthcare system or a country needs to have to adopt AI into its day-to-day practice in terms of feasibility? Is it here and now, or is it a pie in the sky? What do you think about that?
Well, I think there's no doubt about it. It's here and now. There are many techniques, fairly basic techniques in AI which can be used today. For example, there are systems that help in the home management of chronic diseases, particularly hypertension and diabetes, which are quite successful, quite widely deployed now. And they do some basic AI coaching, remind you to take your measurements, help you to interpret the measurements, help you with medication adherence, etc., and help you interact with your clinician, help you reach out to your clinician or help your clinician reach out to you when appropriate. And those techniques are also starting to be applied in mental health so people can be discharged. Also in hospital at home, which is a very exciting area. If we can avoid admissions or decrease lengths of stays in the hospital by discharging people and giving them some remote management at home, as well as perhaps home visits. But we can give them automation at home, and that will, of course, be a combination of automation and also clinician contact through audio, video, messaging, etc. So all those things are are here, and they actually require fairly basic infrastructure in terms of connectivity, internet, etc. Now, that is available in many countries, but not all. And so if we look at situations such as in Africa, for example, in some of the developing countries, the infrastructure is not as prevalent from a couple of perspectives. But it turns out there's an amazing amount you can do just with text messaging. And that has been demonstrated quite widely in developing countries. Some of it involves AI, some of it doesn't involve AI, but simple symptom checkers have received a lot of attention, and they are pretty good. They're not anywhere near as good as a clinician at this stage, but you have to adopt a slightly different standard of comparison, because the comparison is nothing. People who have no care whatsoever in terms of managing a child with malaria, they may need to find out where they can get the anti-malarials. They may need to get help for the child, so they can get basic help in some of these countries simply through text messaging, which is very, very powerful. So I'd say even where the infrastructure is poorer, basic AI, and there's some extremely impressive work that's being deployed in both Africa and India around that, using basic infrastructure, which is basically messages and telephone calls. Around maternity, there's our outstanding examples in India around maternity, maternal health, and infant health, for example. So I'd say basic infrastructure, a lot can work and AI can be applied. I would say the one area where we might need more investment, and this is a call for international organizations, NGOs, etc., is the tuning of the models to work in those areas and the providing of the most relevant materials. In many cases, the clinicians will have a smartphone, even in relatively poor areas, but we need to give them tools that they can use from their smartphone, which are applicable to their area, that are tuned for their area, that know about deficiencies, know about current conditions around infectious diseases in their area, are aware of certain social taboos and so on. Those all need to be invested in and tuned up for those areas. Because look, let's face it, that's where the birth rates are high, where the future of the population is coming from. And if we don't invest in those areas, we're shortchanging the whole future of the world's population. So yes, a lot can be done today. A lot more needs to be done.